Hello, I'm Dr. Thomas Stahl, Regional Director of the MedStar Colorectal Surgery Program and Interim Chairman of the Department of Surgery at MedStar Washington Hospital Center in Washington, D.C. I will be presenting this lecture on persistent and recurrent Clostridium difficile colitis. I have no disclosures. Clostridium difficile or C. diff infection is the most frequent cause of nosocomial diarrhea and causes significant morbidity. In extreme cases, infection can result in death. Persistent and recurrent C. diff makes our attempts as physicians to eradicate this infection extremely difficult. By the end of this module, the listener should be aware of the etiology of persistent and recurrent Clostridium difficile infections, be able to determine clinical practices to help prevent the spread of Clostridium difficile infection, and create a treatment strategy for Clostridium difficile. C. diff is an anaerobic, gram-positive, spore-forming bacillus that can be treated with either oral or IV antibiotics. However, with the increasing incidence and development of more virulent strains in recent years, has led to more cases of persistent or recurrent C. diff infections. C. diff is the most prevalent cause of antibiotic-associated nosocomial diarrhea, with roughly 3 million new cases each year. Transmission of C. diff occurs by the fecal-oral route or through contact with fomite, which can be found on contaminated hospital surfaces and carried by healthcare workers. These spores are extremely resilient and require that hands be washed with chlorhexidine soap and water, as alcohol-based antiseptics are not sufficient enough to eliminate the risk of transmission. In addition to proper hand washing techniques, gowns and gloves should be worn by everyone entering the rooms of infected patients or those suspected of being infected with C. diff. Furthermore, patients may spread the infection to other patients, and therefore they should be isolated as soon as infection is suspected. 20 to 50% of adults in hospitals and long-term care facilities are colonized with C. diff, adding to the difficulties of eliminating this infection. Though C. diff is often thought of as a hospital-acquired disease, there has been an increase in community-acquired C. diff infections that may not be associated with antibiotics or recent hospitalizations. The pathogenesis of C. diff infection after being exposed often begins with antibiotic treatment or chemotherapy disrupting the normal colonic flora. This disruption allows C. diff to flourish and produce toxin A and toxin B, which cause mucosal inflammation and injury. This disruption allows C. diff to flourish and produce toxin A, otherwise known as enterotoxin, and toxin B, cytotoxin, which cause mucosal inflammation and injury. Mild C. diff infection often presents as watery diarrhea up to 10 to 15 times per day, abdominal pain, cramping, fever, and leukocytosis. The infection can progress to moderate and severe disease. These patients can develop sepsis, pseudomembranous colitis, or fulminant colitis with bowel perforation, toxic megacolon, and even death. The most significant change that has occurred in the epidemiology of C. diff infection has been the evolution of hypervirulent strains such as BI NAP1027. This particular strain produces significantly higher levels of toxin A and B and also confers fluoroquinolone resistance. This strain also elaborates binary toxin. The role of this binary toxin is unclear, but it may act synergistically with toxins A and B to contribute to a more severe disease. Risk factors for developing C. diff infection have been classified as primary and secondary. Primary risk factors include patients over the age of 65, antibiotic use, severe illness, and hospitalization. Secondary risk factors include gastric acid suppression, which includes the use of PPIs or H2 blockers, gastrointestinal procedures, chemotherapy, inflammatory bowel disease, immunosuppression, and living at a long-term care facility. In addition to these risk factors, in patients infected with C. diff, low levels of vitamin D have been shown to be an independent predictor of poor outcome and associated with higher rates of recurrence. First and foremost, patients who present with significant watery diarrhea should be tested for C. diff infection. Diagnosis can be confirmed with a stool test positive for C. diff or by endoscopic exam. Laboratory tests for stool testing include cell culture, polymerase chain reaction to identify DNA coding for toxins, enzyme immunoassay for C. diff toxins A and B, enzyme immunoassay for C. diff glutamate dehydrogenase, and cell culture cytotoxicity neutralization assay. Currently, cell culture is the gold standard as it has nearly 100% sensitivity and specificity. However, it is extremely labor intensive and the results take a while to return. Therefore, PCR testing is typically the preferred testing method because the results are available within an hour and it has a sensitivity greater than enzyme immunoassay tests. Though initial testing of symptomatic patients is essential, there is no role for further testing once symptoms have resolved. In line with this, there is no role for testing asymptomatic patients and healthcare workers. In addition to the laboratory tests used to diagnose C. diff, plain abdominal x-rays, CT scans of the abdomen and pelvis, and endoscopy have been used as adjuncts in diagnosing C. diff. The imaging studies often show colonic thickening, free perforation, colonic distension, or megacolon. Endoscopy often shows pseudomembranes, which are nearly pathognomic for C. diff infection. The next 4 images, including the abdominal x-ray on this slide, are from a 67-year-old female with toxic megacolon, pseudomembrane development, and mucosal sloughing. This x-ray shows dilated transverse colon. The CT scan shows a dilated colon and mucosal thickening. And the following images are from endoscopies performed on patients with C. diff infection. This is the classic endoscopic finding of pseudomembranes associated with C. diff infection. This is a colonoscopic image of pseudomembrane sloughing that can be seen with C. diff infection. This endoscopic image shows a thickened, hyperemic, edematous mucosa in a patient with C. diff infection. The first step in treating patients with C. diff is to stop the offending antibiotic. Discontinuation of the offending antibiotic is necessary because continued use will significantly decrease the cure rate and increases the time to resolution of diarrhea. Following that initial step, the treatment will depend on the severity of the disease. Patients with mild disease, that is, those with watery diarrhea, minimal abdominal pain, and cramping only require oral or IV metronidazole. Patients with moderate to severe disease, that is, those with increasing fever, leukocytosis, or signs of end organ damage, require oral vancomycin, which may also be given as an enema. Patients who initially presented with mild disease but who do not improve on metronidazole after 5 to 7 days should then be switched to oral vancomycin. Currently, it is also recommended that antiperistaltic agents used to treat diarrhea should not be used in patients with C. diff infection, as it may cause worsening of the disease. Moderate to severe C. diff can be treated with oral vancomycin since it has topical effectiveness. Enemas of a liquid vancomycin solution can also be considered. Colonoscopies may be helpful in treating patients with moderate to severe C. diff infections since the liquid vancomycin can be administered to the proximal colon in the form of an irrigation solution. Treatment of mild disease that doesn't improve with metronidazole is a switch to oral vancomycin. Fidaxomicin is a macrolide antibiotic that was FDA approved to treat C. diff in 2011. It has been shown to be comparable to vancomycin and led to significantly lower rates of recurrence of C. diff infection in phase 3 clinical trials. Due to the fact that it has minimal activity against gram-negative bacteria, it may help support gut flora in a rebuffing recurrence. The majority of patients respond well to treatments and have resolution of symptoms with metronidazole and/or vancomycin therapy for 10 to 14 days. However, roughly 20 to 30% of patients have recurrent C. diff infection with increasing rates of recurrence with each successive episode. In the clinical setting, it's impossible to tell the difference between a recurrence that develops as a relapse of C. diff infection with the same strain of C. diff, or if it's a reinfection from a new strain. However, recurrent C. diff infection does not seem to be due to resistance, and therefore it can be treated as previously discussed. If recurrence occurs more than once, treatment recommendations become less straightforward. Metronidazole is not used to treat recurrence after the first episode because prolonged use may lead to neurotoxicity. Second recurrences should be treated with a tapered plan with pulsed doses of vancomycin for 6 weeks. Recently, fidaxomicin has been used as an adjunct, particularly in patients on other antibiotics for systemic infections. However, there are no guidelines as of yet for its use, and it currently costs more than $2,800 for a full course, inhibiting widespread use. In addition to the traditional antibiotic therapies, there are also non-antibiotic treatment options for C. diff infection. These treatments include probiotics, intravenous immunoglobulins, and fecal microbiota transplant. In regards to probiotics, there are no significant data supporting their use, and the lack of quality control and regulation makes them unreliable adjuncts. Immunoglobulins may be helpful for severe or recurrent C. diff infections as supported by several case reports. However, no large study has shown this to be true. Fecal microbiota transplant has been very promising in patients with persistent or recurrent C. diff infection. In a review of 317 patients, it was shown to lead to a resolution in 92% of persistent and recurrent C. diff cases. This slide summarizes the medical treatment in a table format. When patients fail medical therapy, surgery can be considered. Severe C. diff infection is often defined as clinical signs of end organ dysfunction, mental status changes, profound leukocytosis, increasing lactate, vasopressor requirement, or worsening abdominal exam. The most agreed upon procedure for these patients is total abdominal colectomy with end ileostomy. Due to the fact that these patients are severely ill, it is imperative to expedite the time the patient is under general anesthesia to avoid hypotension and ischemia, and therefore there is no role for an anastomosis, as this increases the length of the time under anesthesia. However, a new procedure is gaining interest as an alternative method for aggressive early surgical treatment, or in those for which the morbidity of a total colectomy may be too high. This procedure is the creation of a loop ileostomy with colonic lavage of 8 liters of warmed polyethylene glycol solution and subsequent antegrade colonic treatment with vancomycin. A group out of the University of Pittsburgh reported that this procedure could be performed laparoscopically in 83% of patients. The results showed a significant decrease in mortality rates, 9% versus 50% in the traditional total colectomy with ileostomy group. This image shows the surgical intervention with total colectomy. The patient had severe C. diff infection, which caused toxic colitis and perforation. Overall, C. diff infections continue to cause numerous problems, and treatment of persistent and recurrent disease can be very challenging. Further trials are needed to definitively determine protocols for the treatment of persistent and recurrent C. diff infections. I'd like to thank the MedStar colorectal surgery program, as well as a few individuals who contributed content for this presentation, whose names are listed here. Thank you for your attention.